I do want to talk about the actual treatment first, and then let's go into that process of what it's like to be in a clinical trial. So, your clinical trial was acalabrutinib and lenalidomide with also rituximab. Is that right?
Correct.
Okay. Um, can you describe the cycles and then, yeah, just sort of talk about what that looks like?
Did they change the bags on this?
So it's the same size bag, but it is a different bag.
It's clear now.
Yeah.
It's
Yeah,
like
it's less
this is
like
the first time it
glassy
looked like
almost.
that.
So the first 4 weeks, you get Rituxan every week, and then after those first 4 weeks, you'll get it every 56 days after that. And then the other two medications are both oral. So the Rituxan is an infused. You go to the hospital to an infusion center and do that. So the first 4 weeks was back to back to back to back, 4 weeks in a row. And then ever since then, I just go in every 56 days. And the pills, I take a calibrutinib every morning and every night, every single day. And I have for over 2 years now. And lenalidomide, I take like birth control, 21 days on, 7 days rest. And I've been doing that for over 2 years now as well. The first year, I took 20 milligrams of lenalidomide. And then for the second year, they let me reduce the dose to 15 milligrams, just like, basically a 25% reduction of that drug to sort of give a little break, but hopefully, reduce the symptoms by 20 or side effects by 25%.
Yeah, which we're going to dive into because that's what a lot of people have questions about, right? Is the impacts in terms of side effects. Well, first of all, when they did allow you to do the 25% reduction in the lenalidomide or the Revlimid, did you notice any differences? So, like, what were the side effects before and then after? Could you notice anything?
It's so hard because it's like it's so hard to measure them. But I do remember that the first year was way harder. I remember the beginning, the first 6 months was way harder. And I don't know if that's you just get used to it or your body gets used to it or you adapt. But I do remember that, the side effects were worse, in the beginning. And maybe it has to do with just I'm managing it better now. I don't know. But I can tell you that for me personally, acalabrutinib is causes headaches. It just straight up causes headaches, and they resolve from caffeine. Like if you get a headache and you drink a coffee or you take an Excedrin that has caffeine in it, it's pretty, pretty quick. It goes away. And Dr. Ron, who's been, it's a phase 2 clinical trial, it was her tip on that, and it worked. If I ever got a headache, sometimes I wake up in the morning and just be like, oh, my head is killing me, and like, with 1 cup of coffee, and it would start to fizzle out. So that was, that's solved a lot. Luckily, I like coffee. I drink black coffee every morning, so
I was going to
you
ask.
know yeah. If I didn't drink coffee and I was having to take, Excedrin every single day, I would, I don't know, I might feel differently about that.
Right. Well, Jason,
Um,
quick question about that. So with the headaches, like how often would you be getting them? How bad did they get? And then in terms of the coffee, like, so does that mean you're drinking like 5 cups a day? Like how long would the coffee last in terms of helping?
sure. So, I mean, I was a 3 cup of coffee drinker every morning to begin with before all of this. So, I mean, the headache is every day, for me, it's every single day, but it subsides every single day from caffeine, from coffee. Now, normally, once, if I wake up in the morning with the headache and drink the coffee, it goes away. I normally don't get a headache, for maybe not get one for the rest of the day. If I do get one in the afternoon or the evening, I could pop an Excedrin if I don't want another cup of coffee, or I could drink another cup of coffee. So, but it's not every day that you get a second round of sort of the headaches. It seems like waking up with the headache is was my experience.
Okay, thank you for that. So fascinating. I'd never heard of the coffee or the caffeine bit of it. Any other side effects that were really, really tough?
So it's hard to tell like which ones are doing which ones. So these are just my opinions, and I really think the acalabrutinib was causing the headaches, and then the lenalidomide causes. I feel like it causes a ton of fatigue. I feel like that's the pills that are causing all of my fatigue, and that's my number one side effect. That's my biggest problem. I'm very just like it's I want to say like tired, but fatigue isn't tired, and I want to say weak and fatigue isn't weak. It's like put those two in a blender and it's something else. But lenalidomide hits me pretty hard. If I go to work and I'm moderately active throughout the day, I'll come home and then like that's it for the day. I'll be on YouTube in bed for the rest of the evening. So um, fatigue is the biggest side effect from lenalidomide.
And and I'd like to dive into what that means. People hear fatigue and they hear tired or something like that. You were sort of pointing this out just right now. If you were to try to put into words, what's the impact to your quality of life? So without it, a normal day for Jason, and then with the fatigue, what does that become?
Sure. So I mean, before I started, I mean, even when I was having symptomatic with those hives, like I was out to dinner, right? I was meeting friends, I don't do that anymore. If I do a work day, like that's it for me. Like I don't have anything after work. There is nothing left for me to give, in terms of like, I can do things like sometimes I had a doctor's appointment at 2 o'clock yesterday, and like the thought of having to get up and like go into Manhattan and like come back, like just the fatigue, it's like a level of exhaustion that is just like, I don't want to do that. I don't want to do that. It's like, I don't know if you've ever, for people who've never been on treatment or cancer, it kind of been like, if you've ever been so tired where you don't want to take public transportation and you just pay for that car, that lift, like that's fatigue, right? Like you're like, I can't deal with getting on a train right now. I can't deal with getting on a bus right now. I'm so lethargic. I'm paying for a Lyft or an Uber. And I don't know, maybe that's a New York City analogy, but that's probably like, and that's how I feel about like, just like a lot of things, like walking the dog, like, I just don't want to do it. So yeah, I mean, I used to play tennis. I used to go meet up with friends all the time after work. I don't meet up with anybody after work. I don't play tennis anymore. The amount of hours I have to dedicate to the day are a lot less, and I'm not what I used to be during those hours.
And that's a tough shift in sort of any way you slice it, right? So of course there's the first order impact of I just can't make the same decisions anymore. I can't see my friends, and then that can lead to I mean, that's like social isolation to some degree, right? Like it's isolating to be experiencing this. You're so young. Um, how does that, I mean, because that's what I want to bring out. It's like, okay, sure, you can say one side effect is fatigue, but actually what that means for person A and person B is something that has ripple effects. Even, can you like, I mean, it's like, oh, I used to cook. Now I don't have the strength to get up to the kitchen. I'm like, forget it. I'm just going to order something, right? Like these sorts of decisions.
Yeah, totally.
So, on that note, was there anything that helped you through the fatigue?
So I'm still working on it. I met with an integrated health doctor yesterday. That was my appointment, and we talked. The soup of the day was fatigue, and this doctor, is at Well Cornell, like a real doctor, board certified doctor, and we were talking about solutions for it. And one of the things we talked about was potentially doing some weight training and some cardio, even though that sounds like totally counterproductive and the exact opposite of what you would want to do if you're so tired. But we talked about, strengthening, building muscle mass and strengthening the heart could potentially alleviate the fatigue a little bit or improve, my quality of life. So, it's a long process. We talked about starting like really small and, building up to maybe like 150 minutes a week combination, maybe like 5 days a week. And then maybe year 2, punching up to 300 minutes, but in very, very, very small increments. So, that may be a solution. I'm going to try, but it's not like, boom, that's fixed. It's like, it's going to be a path and a journey. And, I have to do the work to hopefully have a little bit better quality of life. Because for me, my protocol is I'm going to keep doing this therapy for as long as it continues to manage my disease or until I can't handle it anymore, so, investing into this, idea may be worthwhile for me, considering I'm going to keep on keeping on taking these medications. So.
No, and I'm just so glad that, we're in an era where this is even available as an option because, and I'll ask you more about that in a second, but first, how are you doing? I know it's been over 2 years, and how do they check? What's the follow-up procedure in terms of not the clinical trial portion, we'll talk about that in a second, but in terms of monitoring the MCL?
Sure. So also, I'm incredibly fortunate because the clinical trial, they're trying to get FDA approval, and there's people that are analyzing data, and there's research, and so I receive MRD tests regularly during the clinical trial for the formal 2 years. I got one, before I even started, and then at different intervals throughout the trial. And those, from what I understand, even though aren't FDA approved for mantle cell lymphoma, the researchers are able to identify, if there's any cancer cells in my blood down to like something very like 1 in 2 million or something like that. It's from what I understand, it's like, a very sophisticated science and test. So we know from my last MRD test, which was that data is from like 3 months ago, that there's still a minute amount of cancer cells in my blood. But if I wasn't getting the MRD test and I was just a regular, getting R-CHOP or whatever, and not on this clinical trial, and they just, sent me to get a PET scan, they would tell me that I'm in remission. That's what my doctor said. So she goes, but I can't say that to you because I have this other test over here that tells me that, the truth, in a way. So she said, let's call it metabolic remission. So all of my lymph nodes are now the same. They've shrunk down to a size that fits into like the normal zone. And none of them are like lighting up like a Christmas tree like they used to. So, from a PET scan point, I look good. But from the MRD test, we know that it's still present. But again, they use the word minute. There's a very small amount. So at the 2-year anniversary, which was last month, they pulled blood for another MRD test, but I don't have those results back because in a clinical trial, they do it in batches. So like I'm in a batch of a pod of people. So those results get released once the whole pod sort of completes and finishes. So, I'm hoping that when that result comes back, I don't know if it can be better than like minute, but, I would love to hear complete remission, which would mean there's no things. But again, my doctor says don't get hung up on, the name of complete remission because, there really isn't a cure for mantle cell lymphoma. Like, I believe there's some doctors who think they've cured some people, but they'll say like, I don't know until, they get another 20 or 30 years down the road and die of something else,
Right.
But So it's, mantle cell lymphoma is new. I think it was like, in the 90s that it was even really discovered. And, I think for the first, decade and a half, they didn't even know what to do with it, and didn't have, their, they didn't have treatments and therapies that were specific for mantle cell lymphoma. They were just giving what they were giving, to another disease until they did their research. So it's new, in terms of medical error, it's a newer cancer that they're still, I think, trying to understand and treat.
Yeah, no, it is. And also, I'm so glad you brought up MRD, which is minimal residual disease testing, MRD. And yeah, how people are touting it as the wave of the future because it can be a lot more precise for blood cancers, at least right now. It's just labs and then they just send off to do a different test, right? Nothing different procedurally for you.
Yeah, so I go in every 28 days for just standard blood work, because all these pills drop my white blood cell count. So before they give me the next bottle, I have to be at a certain level, or no meds for you. And so when they do the research tubes, they'll just be, when they're already taking my blood, there'll be another pouch with two vials that are basically in a special bag. And then those two vials get sent to another specialty lab. They say research on them, and it goes to an outside lab outside of my hospital. And that is where the clinical trial, I don't know, I assume that's where they're crunching the numbers or whatever they do. But yeah, it leaves the hospital. It goes to an outside lab.
I like the image of like, what are they doing back there? Like on these machines and doing number crunching.
Yeah.
So last question on this. You pointed to MRD testing and also the fact that the lenalidomide and the acalabrutinib are both pills that you take orally. These are all results, of course, of these advances. There's been a lot that's happened in just the last 5 years, 10 years. What's the impact to you, especially I know because you have such an attachment to the idea of chemo because of your mom's experience. So what has been the impact to your life, both mentally, emotionally, and then just even in terms of day-to-day living, to be able to take the pills, right? Instead of going into the infusions and getting all that done.
Yeah, no, I'm really grateful that I had this option. And, it's been 2 years and it feels like it was the right decision for me, and feels like, maybe it was not a good idea to make decisions based on those emotions, but it turned out this was the best choice for me. So, those were things I probably should have worked through with a therapist or whatever, those feelings and emotions about, cancer treatment. But regardless, I can look back now and said, I still made the right choice. This was the right choice for me. And, I was the type of person before, like I said, when I went to that PET scan, like that was the first time I got an IV. I didn't really like needles. I was like the person who's like closes their eyes when you get a flu shot, like I that was me. Like I'm such a different person now. Like I can literally watch them put an IV in now. Like I've had so many IVs. I've given so much blood. I'm even to the point where I shock myself that I will volunteer to give my blood to like LLS for a thing like. And I'm the type of person before who would be scared to get a flu shot. So I've surprised myself with my self evolution with all of this stuff, because I really didn't like doctors and going to the hospitals, and I just had a lot of bad memories from I've been to an infusion center with my mom in the 90s. I just had like a lot of bad memories
Right.
of all that. So I've shocked myself with what I was willing to do, and with the Rituxan is definitely like when I get Rituxan infusions, I feel really good about it. I feel like this is like, even though I'm in an infusion center, I'm like, this is a good drug. This is helping me. So I feel really good about that.
That's awesome.
There's-
Yeah, it feels like there's been a shift for you, like mentally too, in terms of all this because of your experience. You've had to confront a lot of these feelings that you had from before, and then even if you remember when you were younger and having to, it's just like the logistics of not even just the needles, but like making the time to go and travel to the infusion center and spend a whole day there or hours there, doing the blood work before the infusion, making sure you can get it, taking shots because your blood counts are low, like that whole cycle, being able to put that aside, with the exception, of course, of every 56 days Rituxan, but that as opposed to like weekly or batches of daily infusions, right? Like having to deal with all that. Has that made a big difference?
There's pros and cons of both. Like, the first 4 weeks, like I said, I was there every week, and then I go back every 28 days for the blood work and to meet with the clinical trial nurse and to get the medication, and then every other visit's that. So with the clinical trial, it's very like rigid. Like I know my schedule like a year out, like I know every single, every 28 days on a Wednesday, I have to be there. And during the clinical trial, it's like you can't really, it's like, you can't be like, oh, I'm going to Hawaii, can we push this a week? Like it's normally a no. Like you have to, I think there'll be like, there's like a little bit of grace, like 1-2 days maybe here and there, and make a special exception, but then it changes the whole schedule. Like if you change 2 days, then your whole year changes. It's that serious. There's pros and cons, I guess, to everything. I see what you were saying, but also with a clinical trial, there's just a lot of, accountability and a lot of appointments,
That's
It's not like I go to Walgreens and get these pills. Like they're just not approved for the frontline treatment. I have to pass all these tests to get them. I have to fill out paperwork, turn in diaries.
I actually do want to get, this is a great segue, but thank you for clarifying, because that's true. If this had already been FDA approved, you were popping pills at home, like it was, that you could pick it up at Walgreens or even, just over the counter, that would be one thing, I guess, right? That's a different impact to quality of life. But with the clinical trial, is very regimented. There are a lot of things that you have to do. So I see what you're saying. So let's segue into the logistics of being in a clinical trial. First, before you got in the clinical trial, what did you have to do? Was there a lot of paperwork? Did you have to meet a clinical trial nurse, give your passport? Like, what was the deal?
Yeah, no, it was like a stack of papers this thick, and you're supposed to sit there and read through the whole thing. It's kind of, it seems like a contract. There's a lot of like, if you die of a heart attack, you can't sue us. There's a lot of like stuff like that, like, 8 pages of potential side effects, and if these happen, sorry, we're not responsible. And there's also like, they outline a lot of like the financial things, like your insurance is still going to be billed for Rituxan because that's standard care. You'd be getting that anyways, things like that. So it seems very legal. The paperwork comes off very legal.
Right. A lot of covering bases, because this is, it's a clinical trial study. You just mentioned something about insurance, which I think a lot of people, of course, it's like financial implications, depending on what kind of insurance you're on, or if it's Medicare, there are different rules here. So was there any issue with insurance beforehand, or anything where you were like, wait a minute, I don't know if I can do this?
No, there wasn't any issues in terms of like my insurance with the clinical trial. So basically, the way the clinical trial was set up is like they knew what was standard care and what wasn't. So like they know MRD tests isn't standard care. So then they're footing the bill for that. They know rituximab is standard care. So they tell them bill that through the insurance. So anything that, was gonna be provided for me anyways is getting billed through the insurance. And then anything that is like above and beyond that is being paid for by the clinical trial.
So that's a great note, is that you were told this is no cost to you. If you do this because, you're participating in this study, there's no real additional cost to you.
Right. And I had a lot of questions about like, okay, what happens after? Are you going to kick me to the curb? And so I was told, no, if this works for you, and you complete the 2-year clinical trial, we'll continue to give you the medications as long as it's working for you and your doctor, you guys, together decide that. And so, yeah, I finished the clinical trial formally 2 years, and my doctor and I decided together to keep going. And the clinical trial has continued to give me these 2 medications, and they're not billing it through my insurance. They're the same process of how I was getting them before, which there's a lot of because they're not FDA approved and they come from a specialty pharmacy, especially lenalidomide coming to a mantle cell patient, it comes from like a research pharmacy. And so like they call me and I have to answer a whole bunch of like survey questions. Then I get transferred to somebody else and I get all these like answer yes and no to these questions, like, because lenalidomide causes birth defects. So there's like, have you had sex with a female who may become pregnant? Yes or no? It's like a lot of like surveys like that. And they're like, okay, you've completed your survey for this month. You will have to complete a survey every 28 days. Your next survey is available on this date. So that's kind of the process. So, and then you get a shipping confirmation from the pharmacy. We've shipped your pills to your doctor. You will get them on your next visit. So that's how one comes. And then the other one, I think, just comes from the pharmacy internally. But it's grants. There's the clinical trial. This one, that I'm on is supplied by grants. So there's grants money that's paying for these pills to get there. And they're continuing to pay for them for me to continue on, which, I appreciate, but they're also, going to be getting more data and more information. Like, I think they're just as excited that I'm continuing as I'm as excited to continue.
Which is great. Like, this is the ultimate perfect match, right? It's working for you, and it's also information for them that will hopefully help future patients down the road. I hadn't heard that process. So it is every 28 days, you're having to call in, take the survey. Then it's like, okay, check mark, Jason's done this. We can give him his next shipment.
And then I get transferred somewhere else and have to do yes, no questions. Like, you can't donate. Have you donated blood? Have you donated sperm? All these. And I believe it's because, something to do with the FDA and not being I assume, but
right.
I take the survey and then I show up at the hospital. They take my blood. They send it to a lab like right down the hall. And I sit there for about 45 minutes waiting for the results to come back. And then if the white blood cell count and the neutrophils or something like that is good, then they hand me the pills. But I don't get to leave until I get the blood work back.
And if the neutrophil count isn't high enough, what happens? Delay?
So I've never not gotten my pills. So I've never, they've always been like, your counts are good. Your counts are good. I haven't had that bad news yet, which I feel really, really fortunate about. So, but yeah, like my white blood cell count, like just sits at a 3, like right across the board, like a piece of paper. So, it's low, but it's not like, it's still like right at the bottom of the, the acceptable mark, but it just stays there.
Right.
Yeah.
No, and you look great. I know you have a lot of fatigue and other things, but it's really good to know that you've had a great response. And just a couple more questions here. I don't really know what baseline is like in terms of, if you were to have gone through RCHOP instead, like, did your oncologist say, look, your response has been like this compared to what the typical response is on the traditional route? Was there any sort of picture there given to you?
So it's a great question. So I've never asked like, so how do I compare to like, if, to that. And she's never brought it up to me, but she's been very excited about the response in general. Just like everybody's seeing a response. This is, we have people that are in complete remission, on the clinical trial. I'm very excited that you responded and at the level that you responded. I think we should be happy. So she seems to be thrilled with just like in general how everybody's doing. Like, I don't think there isn't. I think it was like everybody got a response. There wasn't like one person that like it just didn't work for. So I think that there's some excitement around that. I really don't know the answer to your question, but again, for me, I'm glad I didn't do the R-CHOP, and I don't, I don't know what's next for me. It's kind of one of these, it's like a game of chess with mantle cell lymphoma for me. Like, I'm going to keep doing this for as long as I can do it and it manages the disease. And then, we probably all assume at some point, like this is going to relapse and comes back, and then I'll need to try another therapy. And I think, if that's the case, I would hold out to do a traditional type of chemotherapy that would be like, going into like a stem cell transplant or CAR T cell therapy or something like that. But just to do like just straight up, R-CHOP or chemo as a treatment is not appealing to me, unless it's like, we're going for a home run on this. We're going for the stem cell transplant. We're going to do CAR T cell therapy. But as, just like a typical treatment, I wouldn't like, and you talked a lot about like the anxiety, the scan anxiety. And I'm in a lot of cancer support groups. Like there's anxiety between like, okay, you do the chemotherapy and now, okay, go off and we'll scan you again in 3 months and see every 6 months. Like that sounds anxiety driven to me. Like I love the fact that I go to see the doctor every 28 days and this treatment continues. Like the I feel like I'm doing something by taking the pills, like every day,
Yeah.
When you talk about managing the disease, I feel like there is a management thing happening here. Whereas like if I just did R-CHOP, it would feel like, all right, let's whack it. And now you go over here and we'll see how long that lasts, where this process feels a little bit more like we're staying on top of it.
That's such a great point, because for some people, I think they think of managing this almost like a chronic disease as, oh, that sounds like a lot. But the flip side to it, and it's very real, is exactly what you described. You're still under, the care and attention of people who know what they're looking for. And so you're being taken care of essentially. Whereas, yes, like
getting MRD tests for free.
Right.
Like I know, like, most lymphoma patients are getting PET CTs if they're lucky, every 3 or 6 months. I've been getting MRD tests every 3 months. They're giving me another one in 4 months. And then they said, if you stay after that, every 6 months. So twice a year for free for being in a clinical trial, I'm going to have information that you shouldn't be getting.
Yeah.
It's just like, it's MRDs aren't approved for mantle cell lymphoma, A, right? But then like B, there's no insurance company in the world, I think, that's going to just start doling out MRD tests for mantle cell patients.
So true.
This feels like I'm really being watched and managed at a level way beyond what is even, it's futuristic. It's beyond what is even possible if I wasn't in a clinical trial.
Absolutely. You get first access to things that are not available to most people out there with mantle cell lymphoma, which, and that's why I think it's so great to be able to hear your story, because you really exemplify, like, this is the human face of what it's like to be in a clinical trial. And of course, not everyone has had the same response. And you are much younger than a lot of other mantle cell lymphoma patients, but it's still, I think, a great story for people to learn from. The logistics part of it, I want to wrap this part of the conversation. You were talking about the journals and submitting, and I know it's very regimented. Can you give us more of that color of what you're having to do every day?
Sure. So yeah, I can show you one. I have one right here. So it basically just says like study, drug diary, and then you have to log, date, time, and the number of pills you take every single day. So, I'm taking acalabrutinib every morning and every night, and then I'm taking lenalidomide 3 pills every day. and then I take 21 days and then 7 days off. So even the diary will remind me, like, do not take on those days. So I have the diary, and then it's very important that I bring all the pill bottles back. Like, they have a freak out if you don't. They're like, where is it? You have to they'll have to write a report, he lost the bottle or something. But like in one instance, like they know that my cycle is 28 days, so that I should have 4 pills left or something like that of one of these on a 28-day cycle. So, they're like, they're opening it up, making sure there's 4 pills in there that I bring back. And if there isn't, they're, where are they? Or, did you miss any doses? And then randomly every other time or every 3 months, they'll give me a whole bunch of questionnaires, they'll ask it, the questions are kind of like, on a scale from 1 to 5, do you feel close to your family? On a scale from 1 to 5, how do you, so there'll be like a questionnaire, like every 2 or 3 months, like a scalable questionnaire. And then you meet with the clinical trial nurse every time, and you report every single symptom that happened during the 28 days. And you're supposed to just make notes next to the date, oh, I had diarrhea on that day. Oh, I had a really bad headache. Oh, I had chemo brain on that day, or whatever side effect you had. Your stomach hurt on the right side on that day. So you just sort of turn every 28 days, you turn over all the side effects of what you did. That's pretty much it for paperwork. It's the drug diary, the surveys, bringing the pills back, and then just reporting all of the symptoms.
Awesome. Wow. Awesome. Okay. So it is like not a full-time job, but there's a lot of work in terms of just monitoring, and it makes sense. They're wanting to make sure that you're on the right dosage, and then that you're logging everything so they learn from, like, are we supposed to up the dosage or lower it, and how effective it all is, right? That's all they're studying.
Sure, exactly. They're using it for something,
Typically it seems like that's what they're studying in these kinds of clinical trials, and it's phase 2. And you said there are 28 people altogether enrolled, right?
Well, I thought there was 28 people all starting at the same time, and I thought that I got the second to last spot, but it turned out I got the second to last spot of pod 2. And I guess when I started, 2 years ago, they only started 12 people, for the first year. And then after about 11 months, then they started more pods. But the goal is, 28 people roughly for this clinical trial. I believe there's now a waiting list. So it's sort of caught attention, and there's people that want to join. And I've heard that there's even a hospital in Florida that is asking to potentially start, basically, offering the clinical trial at their hospital and then enrolling more people. But I think eventually, as it goes down the road, there'll be, maybe they'll enroll even more people, like in a phase 3, 100 or 200 people across the country. But right now, it's just at Weill Cornell in New York City.
Gotcha. Then my last question on this, and then is really just any message to other people about clinical trials. I mean, now that you've been on one for over 2 years, and you know the ins and outs of it. If they have mantle cell lymphoma and they're not quite sure, they're kind of on the fence. Yeah, do you have any guidance?
I wish I did have good guidance, because I'm in support groups, cancer support groups, and I've heard horror stories, especially of phase 1 clinical trials. So, again, I feel very fortunate and grateful, and maybe I got some dumb luck, hopefully getting into this clinical trial, because it seems to be working. But, it seems, I can only speak to mantle cell lymphoma, because that's what I have, and that's what I've been researching, and that's what I'm knowing. And because mantle cell lymphoma is a newer cancer in terms of if you're talking historically speaking, and really, they're just in the past 10 years starting to create like individual therapies that are designed just for mantle cell. And it doesn't really get a lot of attention because it is the rarest of all the B cell cancers. So, it's the least amount of, diagnoses per year when you're talking non-Hodgkin's B cell lymphoma. But I think clinical trials may be worthwhile looking at if you have mantle cell, because that's where a lot of like the new stuff is happening, because for a long time that you were just getting a lot of the old stuff or repurposed stuff. It almost felt like you were like the youngest child and getting all the used like clothes, like, well, just give them what we gave, all the other B cell, cancers. So I think it might be worthwhile if you have mantle cell lymphoma and you're, looking around and trying to figure out your options. I mean, if I was diagnosed, I'd be seeing if I could get into a CAR T cell therapy clinical trial for mantle cell. I listen to a lot of the LLS calls and a lot of the cancer care calls, and listen to a lot of doctors talk about the stuff that's happening with that. And it just seems like there's a lot of new modern therapies that are actually being, created or tested and designed for mantle cell, and they're not FDA approved. So the only way that you're even going to get a shot at getting them is getting in a clinical trial. But do your research, do your due diligence, and follow your intuition. I feel like I got really, really lucky, but that helped. I showed up at the right place at the right time. That's just luck. That's just like when I go to Las Vegas and I hit the button on the slot machine. That's just luck. But luck happens, and then the rest of it is just doing research and following your intuition and making an informed decision.
No, I'm again so glad that you lucked into this or whatever. And people say I'd rather be lucky than good. And so you got that. Thank you.